2025 മെയ് മാസത്തിലെ 4-ാമത്തെ വ്യാഴാഴ്ച ഞങ്ങൾക്കിതുപോലെ ഇവിടെ കൂടുവാൻ ദൈവം ഞങ്ങളെ സഹായിച്ചല്ലോ. ഇന്നും ഞങ്ങളോട് സംസാരിക്കുന്ന ഡോക്ടർ നോവിനെയും ഡോക്ടർ ഫിലിപ്പിനെയും ഞങ്ങൾ പ്രത്യേകമായി പ്രാർത്ഥനകൾ ഓർക്കുന്നു. ഇന്ന് കേൾക്കുന്ന കാര്യങ്ങളും ഞങ്ങളുടെ ഔദ്യോഗിക ജീവിതത്തിന്, പ്രത്യേകിച്ച് ഈ ഹോസ്പിറ്റലിൽ വരുന്നവർക്ക് മുൻപോട്ടുള്ള ജീവിതത്തിൽ അതൊരു അനുഗ്രഹമായി തീരുവാൻ സഹായിക്കണമേ. ആദ്യന്തം അവിടുത്തെ സാന്നിധ്യം ഞങ്ങളോടൊപ്പം ഉണ്ടായിരിക്കണമേ. പ്രാർത്ഥന കേട്ടതിനായ സ്തോത്രം. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Thank you, Achin. So good morning to everyone. Welcome to this edition of The Quest. I see a huge representation from the ICU team here. I'm sure you've come to support your colleague who will be speaking, Dr. Novin. I just want to say a personal word of introduction about Novin, Dr. Novin Chako John. Dr. Novin was a young junior doctor who worked with us in the Duncan Hospital at Roxall, Bihar for over 2 years. He graduated from the Pushpagiri Medical College, came to visit our hospital for 2 weeks. The 2 weeks became 2 months, and then he stayed on for 2 years. And thereafter, he went to Vellore for his diploma in anesthesia and his MD anesthesia training. And after finishing that, he worked for quite a few years in Bihar in the Duncan Hospital on the Indo-Nepal border, particularly during the crucial COVID years. In many hospitals, you know what happened, including ours. It was a very difficult time, and Dr. Novin single-handedly managed the ICU issues in COVID with the help of his team and many, many lives. When I visited Roxall last year, many staff told me their lives were saved because of the hard work and the 24/7 presence of Dr. Novin's work and what he did there. And I must say that there are many people in Bihar owe their lives to his timely intervention. And it was a joy to hear that he got admission at DRNB in Anantapuri in Trivandrum, finished it, and then he's joined us, our team, and I'm so glad that our ICU team was good. It's only been strengthened by Novin's coming in. So we want to welcome you, Novin, to our quest. And he's feeling a little apprehensive. I said, nothing to worry. This is just family, the believer's family. We are going to listen to you. We are going to learn from you. I've never heard of this word De-Resuscitation. So he said that is a short note in our exam recently. So I came to know all those. But that's something which I don't know. But we have people from all different backgrounds. But I'm sure he will make it interesting for all of us. But just a word of introduction about the topic, I'll hand over to Dr. Mathew, who will share.
Finney sir has already given the introduction of Novin. Actually, we all know Novin as Abel's brother-in-law. But in the past 1 month, he has already become a very, very important part of the team, being very nice with everybody. Staff has already come and told us he's almost like being here for 6 months or more. And we're actually so fortunate to have Novin as part of our team. As told, already strong team has been further strengthened with Novin. And we will soon have Dr. Dan Luke joining us from first week of June. So coming to this topic today, when I told about de-resuscitation to somebody, they were asking, yeah, so it should be like resuscitation and de-resuscitation. I mean, you are doing CPR and then stop CPR. Is it a new word for DNI, DNR, comfort care, de-resuscitate the patient, de-escalate the patient, or something of that sort? But then definitely it's de-escalation. Most of the things are written up on the board anyways. It is not about stopping life care support or any of those things, but it is about resuscitation in the first few hours in shock or when a patient comes into the ED and ICU. And then when do you stop giving fluids? When do you start taking off fluids after the initial phase? It's again a new concept. It has gained importance in the past few years, 2 or 3 years. So let us listen to Novin more about and how do you do it and things like that.
Hello. Good morning, Leah Achin, senior colleagues, my ICU colleagues, nurses, and friends. as Dr. Philip, anyway, thank you for the kind introduction, Dr. Philip, and of both Dr. Philip. Yeah. So, how did I end up in this topic? Because we all, when we prepare for our final exams, we take a list of questions, and we go through it. And then I stumbled upon this topic, de-resuscitation. As Dr. Philip Mathew had given a introduction, the initial introduction, I also thought maybe is it de-escalation of treatment, what we do in the ICU. But de-resuscitation has more meaning to it. And for the next half an hour, let's see what we can learn from this. So as young doctors, we are very zealous in our resuscitation. So patient comes to the ER, or patient gets shifted from the ward to the ICU, and we feel that the patient is hypovolemic, probably because of a sepsis. We aggressively resuscitate the patient. And what happens is over the the days to after the initial resuscitation, sometimes we are not very judicious in our decision about IV fluids, and then we end up edematous and puffy patients. I admit that I had this problem while I was in Bihar. Now, being in Believers, we are lucky to have nephro colleagues who can help us out in getting out this extra fluids. But when you work in a low resource setting, when we try to aggressively resuscitate patients, after some time we are stuck with patients who are edematous, and we are not able to either wean them off on the ventilator, or even mobilize the patient. And because one thing at this outset I want to say is that IV fluids are like a double-edged sword. Definitely it will benefit the patient, because in a shock situation it helps in improving the hemodynamics, and the final outcome of improving the hemodynamics is oxygen supply. If the cells don't get the oxygen, our resuscitation doesn't make sense. So at the same time, we should know more about our IV fluids, because we need to judicially choose which IV fluid is best in each situation. Now, if you look at the ATLS, the latest ATLS recommendations also, they also have reduced the loading dose of IV fluids in a patient in trauma. They have restricted to 1 liter. In my junior doctor days, I remember all the consultants used to say you resuscitate 2 liters of fluid. But now ATLS also has brought it out to 1 liter, because the crystalloids has its own, can damage the endothelial glycocalyx layer. So so what is de-resuscitation? It specifically refers to a goal-directed fluid removal. Now there's a difference between de-escalation. De-escalation means you stop the fluid or you taper the fluid. So here de-resuscitation specifically refers to a goal-directed fluid removal, which involves aggressive and active fluid removal by means of either diuretics or using RRT with net ultrafiltration. So where do we generally use IV fluids? Basically in these 4 situations, that is resuscitation, maintenance, replacement, and nutrition. Now, resuscitation, when it comes to sepsis, the surviving sepsis guidelines have given us a guideline of giving 30 ml per kg within the first 3 hours. Now, though they have told 30 ml per kg, we don't have to take it down just like a commandment, because many times fluids would have been given in the previous hospital. Some may be some fluids on the way. And then on top of that, we again load the patient with 30 ml per kg. So we should be very wise in while we are resuscitating the patient. And at the same time, we need to examine the patient. Now, we know ultrasound has come in a great way into the ICU, and POCUS helps us to a certain extent of helping us in resuscitating the patient. Remember, once upon a time, capillary refill time lost its sheen, but now there's a latest trial called Andromeda Shock trial, which compared capillary refill time and lactate, measuring lactate. Actually, measuring lactate, you need it's an invasive procedure. You need blood sample, but capillary fill time is just a simple clinical bedside examination, and that itself also can help us guide fluid resuscitation. The trial showed that the resuscitation based on capillary fuel refill time and measuring lactate, the outcomes were more or less the same. So we should definitely not, in addition to the POCUS, we should not miss measuring or checking for the capillary refill time. So generally, these are the 4 situations where we usually prescribe IV fluids. Now, maintenance IV fluids, the purpose is for supply of water, glucose, and basic electrolytes. Replacement fluid, we give saline, or in case of GI losses. So now you have a patient in the ICU or in the ward, suddenly the patient had a bout of loose stool or vomiting, we try to replace the loss. And lastly, nutrition. When patients are on nil per oral, we supplement nutrition with IV fluids for a brief period. Now remember, the IV fluid, just like antibiotic, it's a drug. We need to know what type of fluid we have in our armamentarium, basically the balanced crystalloids, normal saline, colloids, crystalloids, and starch. So starch has lost its value in the ICU. The next thing is, do we have a liberal or a conservative approach in giving IV fluids? So many trials have shown, which have compared liberal versus conservative fluid strategy. I will name some of these trials in the subsequent slides. Has shown that conservative fluid strategy had much better outcomes, especially in ventilator-free days, mobilizing the patient, and certain trials showed even mortality benefit. But that's not universal. But the most important thing is that we could have ventilator-free days and lesser incidence of AKI. And we need to choose whether we need to use colloids or crystalloids. Now this is the, all of us in the crowd know the various crystalloids which are available. The colloids, natural and synthetic, albumin, dextran, but in the ICU mostly we only use albumin in very specified scenarios. Now the rationale of fluid in resuscitation is basically based on the Starling's law, where based on, we need to know the patient is on which, is it on the steep part of the curve or on the flat portion. So patient on the steep part of the curve, when we give IV fluids, will respond to improvement in the hemodynamics. But if patient is on the flat portion of the Starling curve, there will not be much response. In that position, in that time, giving more fluids will be harmful. Now, these are the phases of shock, the ebb phase and the flow phase. Now, the ebb phase is the initial phase, what we see. That is, especially in sepsis, you have a vasodilated state. There's intravascular hemolysis. All the fluid creeps out of the intravascular compartment to the extravascular compartment. And that will, and we do an aggressive resuscitation. Later on, once the ebb phase settles, and then we step into the flow phase once the body tries to recover. So we have the ebb phase and the flow phase. Now in the flow phase, body itself to a certain extent can mobilize this fluid back into the circulation. But many times it is not possible. That is where, for example, is classical is the polyuric phase after. Now we have a kidney injury. Once a kidney starts recovering, we see a lot of polyuria. That's the kidney is trying to remove the excess fluid in the body. But in some patients, kidney failure may persist for somewhat a longer period, and that is when this fluid, which is remaining excess in the body, creates trouble. Now, this is the classic Starling's law of movement of fluid across the fluid compartment. So we know the initial part of the artery, we know the hydrostatic pressure is high, and as the fluid moves further, the hydrostatic pressure pushes the fluid into the cells. And once it reaches the capillary end, the hydrostatic pressure drops. And then the oncotic pressure is high, so the fluid starts moving from inside back into the intravascular space. Now, the fluid can come 2 ways. It can enter into the vessel, and some can go into the interstitium, enters the lymphatic space, and then back into the through the lymph, and then into the venous system. But this Starling's law, this Starling's principle is more or less now outdated, and now it is more of the looking at the glycocalyx theory. Now we know the vasculature, it has a very thin jelly-like layer on the surface, and this gel-like layer of proteoglycans and glycoproteins, acts as a selective barrier, and that will regulate the vascular permeability, and they modulate the fluid and protein filtration across capillaries. So the Starling's law is no longer valid, but now we moved into this endothelial glycocalyx theory. So in sepsis, what happens is, because of the inflammatory mediators, the endothelial glycocalyx can get damaged. And then because of this damage, there will be increased spaces between the tight junction, and water and proteins and all seep through and go into the interstitium. In addition, what happens is our IV fluids can also damage this endothelial glycocalyx, especially normal saline. So our excess crystalloids can also damage this endothelial glycocalyx. That will again worsen the third spacing of our IV fluids. So that is a normal vessel with an intact glycocalyx. So whatever from the artery, it goes into the interstitium, and then it comes into the from the venous side. Extra fluid which is in the interstitium goes into the via the lymphatic return. It comes back into the vein. But once, because of a systemic inflammatory event, you have a degraded glycocalyx because of oxidative stress, hyperglycemia, a lot of the inflammatory markers. They cause degradation of the glycocalyx, and what happens is there is increased capillary permeability, plasma protein loss, impaired lymphatic function, and all this lead to the extracellular matrix gets disrupted, and then that's lead to interstitial edema. So in this situation, what happens is the lymphatic return is less than the fluid lost to interstitium. So more fluid is in the interstitial space, and the fluid returning via the lymphatics is reduced. So we get a lot of tissue edema. So what happens with fluids and gel, as I said earlier, normal saline, large volumes, causes hyperchloremic acidosis. Many times in our ABGs we see this. So this hyperchloremia can damage the endothelial glycocalyx, can also cause even acute kidney injury. So once the hyperchloremia causes AKI, that can again affect the fluid balance of our body. Balanced crystalloids like ringer lactate, plasmalide, they have less chloride content and they are less harmful. Albumin, to a certain extent, we believe that the age-old concept is that low albumin state, you give albumin, fluid moves from the interstitium back into the intravascular space. But that's more or less theory. But newer concepts is that albumin has a more protective effect on it helps even in the repair of the glycocalyx. So, and if you're anticipating a lot of IV fluid requirement, guidelines also suggest giving 5% albumin. In the ICU, mostly we use 20% albumin. But if you need a large volume resuscitation, 5% albumin can also help. HES can cause GI damage, AK. But all these, wherever this damage is seen, these IV fluids will damage the respective glycocalyx endothelium within those organ vasculature, leading to their injury. So when we come to IV fluids, just like we follow antibiotic stewardship, basically it's 4 Ds, drug, dose, duration, de-escalation. But in IV fluid, just we need to know some definitions. We need to know diagnosis. I'll touch upon these. Now, it's very important that we know that we choose our IV fluid wisely. We stop it wisely at the right time. So this is a a long tussle between whom to choose. Is it the NS or the RL? So NS has its own problems. I said NS causes hyperchloremia, and hyperchloremia has a lot of side effects in our body, which is not so evident we measure, but at the microscopic or the cellular level, NS is known to saline, especially the chloride is known to cause lot of damage to the cells. That is where the balanced crystalloids have more of the tonicity is much more comparable to the plasma and much more favorable to the vasculature. So there are a lot of trials, as the trials which compared huge populations comparing crystalloids and colloids. But in all the most of the studies, the split and salt, the smart, basics and plus. So these five are basically the landmark trials, comparing crystalloids and colloids, and only the basics showed there was some 90-day survival. Though we talk bad about normal saline, but most of the studies showed that there was not much of difference when they compared saline and the balanced crystalloids. Now we don't use balanced crystalloids so often because it is more expensive than the normal saline which is available in the market. So coming to the definitions, now fluid balance is the sum of all the intakes and outputs, and the cumulative balance is the sum total of the fluid accumulation over a set period of time. So cumulative means every day is balance, positive or negative. We keep adding it up or subtracting. That is the fluid balance. Now when do you call this fluid overload? Now the patient comes to the ICU, if you are able to, many times our patients are sick. So baseline body weight, certain ICUs have high-tech beds where you can even measure the weight of the patient. So you have a baseline body weight, add up all the cumulative fluid balance and you take a percentage. When it crosses more than 10%, we call it that this patient is in a fluid overload state. So a cutoff value of 10% is associated with worse outcomes. Now, early adequate fluid management, this is a goal-directed treatment on an average. That is based on the Surviving Sepsis Campaign guidelines, 30 ml per kg within the first 1 to 3 hours. Now, this is the initial phase. Now when we in the ICUs, when we are assessing patients, and we feel that the patient requires more fluids, we tend to give fluids basically at a much lower dose, like 4 ml per kg, 4 to 5 ml. That's around 250, not 200 to 250, because now we are slowly, tuned to the fact that giving more fluids is bad. So we only give 4 ml. We never repeat this 30 ml per kg. Or in my junior doctor days, we used to say give 1 pint, give 2 pints. We sometimes don't examine the patient. But now we always give fluid in aliquots. You give 200, you give 250. But if once you give, you cannot withdraw it back. So we always give in aliquots, and that is safe for the patient. Give 200, reassess the patient, give 200. So in that way, we are always we are trying ourselves to be within the safe margin. There's something called as a late conservative fluid management. What is late conservative fluid management? So patients within the first week of ICU stay, now patient comes to the ICU, first 2 days you will have mostly a positive balance because we're trying to resuscitate the patient. And the next 2 to 3 days, while the patient in the ICU, patient is on antibiotics or patient has got a good source control. And then we feel that patient recovers within the first week. And that is when we try to aim for 2 days of negative fluid balance. So that is called as a late conservative fluid management. And the late goal-directed fluid removal, that is this de-resuscitation, that's active fluid removal. Now, many times we are not able to achieve diuresis because sometimes their AKI is set in and there's no response to diuretics. That is when we try with diuretics 1 or 2. If it doesn't work, by increasing the flow rate, no response. There's something called as a furosemide stress test, where we give 1 to 1.5 mg per kg of Lasix. Basically, if you see the patient is already on diuretics, it needs a higher dose. Patient who is naive, meaning not used diuretics in the past, maybe 1 mg per kg, and we try to see how much is the urine output, if it's more than 200 ml or not. So if we fail there, that is when we call in our nephro colleagues who helps us in taking out the ultrafiltration. Now remember, when we don't use judiciously IV fluids, patients end up in undergoing ultrafiltration. Ultrafiltration involves insertion of a dialysis cannula. It's a more invasive procedure. So what I want to emphasize is that we need to be judiciously giving our fluids in the earlier stages so that we don't end up are subjecting our patients for invasive procedures. So, so what happens in the process is there's hypovolemic shock or vasodilatory shock. We give fluids, excess fluids lead to intestinal edema, visceral swelling. That leads to intra-abdominal hypertension. Once there's the intra-abdominal hypertension, the compression on the renal vasculature, that lead to oliguria, again fluid resuscitation. So this goes round and round. Then mesenteric vein compression, venous hypertension. Again, we feel that patients who hypovolemic. So we keep on giving fluids, and this goes round and round. So as I said earlier, hypovolemia is bad because oxygen supply is important when we give IV fluids. But remember, hypervolemia is also even worse. So we try to target, between that normal volemia. That is, let us aim to be within that range so that the outcome of our patients are good. So we know this ad we see for a tire. So many times our patients end up in this, in this figure. So when this fluid creeps into the interstitium, that leads to something called as a global increased permeability syndrome. So the flow phase, I set up the ebb phase and the flow phase. Now the flow phase, sometimes the body may not recover. And that is when all this fluid creeps into the interstitium. If the body is healing, with the help in the flow phase, body itself can mobilize the fluid from the interstitium back into the vasculature. So it's an exhaustive list, but you remember, almost all the systems are affected because of increased fluid. Now, in the ICU, mostly we are concerned about the respiratory system. Now, we'll have pleural effusion, pulmonary edema, and the most challenging we face is difficult weaning. We are not able to wean the patient off on the ventilator. And abdominal wall surgeons may have a tough time. There'll be delayed wound healing. And patients with RTA, where their blood-brain barrier is damaged, again, more fluids can lead to raised ICP. And one of the most important things is of the kidney. As I said, the intra-abdominal hypertension can again cause increase in AKI. So what is the evidence? So overall, now from this, these are the list of some of the trials which says that hypervolemia, there's the overall there's increase in mortality in critically ill patient. That is a systematic review by Malbrain. Dr. Malbrain, way back from 2014, has been telling about this, the ill effects of excess IV fluids. There's increased mortality in patients in AKI. That is in the SOAP study. That's a study comparing crystalloids and albumin in septic patients. Then you had prolonged recovery in patients with ARDS also. The current concept is go with conservative fluid strategy, not with liberal fluid strategy. And then worse mortality in septic shock patient, that was in the VAST trial. In patients who are undergoing colorectal surgery, we know that more fluids, more edema, more edema at the anastomosis point, and they can lead to breakdown of their anastomosis. And associated with, again, Dr. Malbrain showed that a lot of fluids again can cause intra-abdominal hypertension. So it is basically, my talk has been based on these, from this article by Dr. Manu Malbrain et al. Now, I don't know how many of us know this concept called a ROSE concept in IV fluid therapy. ROSE stands for resuscitation, O is optimization, stabilization, and evacuation. Again, this is also a short note for us. So ROSE concept here, again, resuscitation is patient-on-patient rescue. And then you have a lot of parameters here in this. There are many advanced hemodynamic parameters which we don't you routinely do, but at least we know the map. We can know the passive leg raising lactates. And then that in the initial phase, it's all about the patient rescue. In optimization phase, it's based on the organ rescue. And we here from the optimization phase itself, we try to cut down our fluid. We look at the fluid, the input-output chart. We take the help of our dear nursing colleagues and try to see how we can optimize our fluid administration. And then we see at the lactate levels, we can measure the intra-abdominal pressure and go with the map. Then come to the stabilization phase. Here again, we're going to a conservative mode. We are trying to get at least two consecutive negative fluid balance after the first week of the insult. And finally is the evacuation phase, where with the organ recovery, we try to see, now we have a goal-directed fluid removal. Now, in this last phase, we have to be careful because aggressive fluid removal again can push the patient back into hypovolemia. So it's very important that, yes, we be aggressive in removing the fluid, but we need to be careful that we don't cause more damage than intended. So if you see this as a graph, the one below we see the ebb phase from minutes to days, and then the flow phase set in. This can be also described as 4 hits. The first hit is the initial insult, that is the sepsis, hypovolemia, and then the second hit is the patient has recovered. Now we know that when an organ is ischemic for some time, and then once it gets its perfusion back, there's something called as an ischemic reperfusion injury. And then third, after that, still if we are not judicious in our management, we move into the global increased permeability syndrome. And if we are over aggressive in the 4th stage, 4th hit, that will lead to hypoperfusion. So the ROSE concept, we have the resuscitation, optimization, stabilization, and the evacuation. So assessment, we know when the patient is fluid overloaded, there will be a negative PLR test. The extravascular lung water index is in advanced hemodynamic monitoring. Now these tests here, 3, 4, and 5, I have not seen. It's all more of a theoretical concept. But I would like to talk something about the VEXes. I don't know. This is when you assess. You have altered GCS, increased hepatojugular reflux, orthopnea, second, third phase fluid, pitting edema, altered capillary refill, raised JVP, increased body weight, fluid accumulation, and increase in the climatic fluid balance. Now, a little about what is venous congestion evaluation using the ultrasound. That's the VEXes protocol, venous excess ultrasound. Now, here basically we are utilizing the 3 veins, the hepatic veins, the portal veins, and the renal veins. So first we assess the IVC, then we move to the hepatic vein, then the portal vein, and then the renal veins. So it's very familiar to many of us. That is the IVC assessment. And then step 2, we come into the hepatic vein. So we see the 3 hepatic veins draining into the IVC. At this point, we can keep a pulse Doppler, and then we get this image. Now, the one that is a systolic upstroke and a diastolic upstroke. So usually the S is more than D. Now, in the mild hemodynamic, we see a reversal. S is short and D is taller. And then severe hepatic abnormality, you see it goes up. So this can be done very easily bedside. So we know whether the liver is congested or not. Then we can go for the portal vein. So portal vein, you go from the lateral aspect in the mid-axillary line. And again, we put a pulse Doppler. And normally we get a wavy pattern. And once the normal pattern is wavy, and once the mild, it becomes more pulsatile. The severe, the pulsatility index increases. So we are able to assess the portal vein. This can all be done with our convex curvilinear probe in the ICU. And the last one is the renal vein. This is quite difficult. We have to go in the posterior axillary line, where we keep again try to get the venous flow and keep a pulse Doppler. And this is what we get in a vein Doppler, not the upper part, the lower part. So it's usually like an undulating flow. Then it becomes more pulsatile. Then the systolic wave disappears, and then only we see the diastole. So now when we come to the grading, usually step 1 is the IVC more than 2. If once the IVC is more than 2, then we go for the hepatic vein. Then once at the hepatic vein, we and the portal vein and renal vein, we see is there any one of abnormal position. Then we say it's grade 1, it's a mild congestion. At this point, diuretics will suffice. But once we move to grade 2 and grade 3, and if the clinical scenario is that we are struggling to wean the patient off the ventilator, then we may need to take an ultrafiltrates. So then grade 2 means when you have a severe abnormality, and grade 3 when you have more than 2 severe abnormality patterns. So when to start? Fluid, always we consider when this fluid accumulation is affecting the organ function. Triggers include increased weight, positive fluid balance, hemodilution, ultrasound showing B lines, massive pleural effusion, the IVC is plethoric, and altered cardiopulmonary function. So there's something called as a PAL approach, P-A-L. P stands for PEEP. Now, it was put forward by Codman et al. Approach. So P stands for high PEEP. Now, the question is how much high? So this PEEP should be equal to the, we need to measure the intra-abdominal pressure using the Foley's catheter and keep the PEEP for 30 minutes, then give albumin. That is 2 into 200 ml of 20% albumin. These are all very costly. Many of our patients won't afford this. And then we put that's Lasix or furosemide. We try to start a bolus and an infusion dose, and we try to get the fluid out. Once we fail it, we go in for a mechanical fluid removal. That's the slow continuous ultrafiltration, intermittent RRT, and the continuous RRT. And during this, while we do intermittent, mostly intermittent or scuff, we face there are hemodynamic changes, so we can always start the patient on a low dose of vasopressors. So de-resuscitation, these are the list of evidences which showed that definitely there is not much mortality benefit, but at least there is more of a ventilator-free days. So a goal of 0 to negative fluid balance by day 3 and to keep the balance on day 7 as low as possible. That's a 2B recommendation. Diuretics or RRT using to mobilize fluids in hemodynamic stable patients. Again, that is also a 2D recommendation. They're not level 1 recommendation, but little down the grades of recommendation. So de-resuscitation in a nutshell. Why? Because fluid overload is an independent predictor of mortality and morbidity. So what is it like? It's basically a late goal-directed fluid removal. And after when do we do it? After in the Rose concept of fluid, after the stabilization phase, where we know the fluid overload can impact the organ function. How we do it? Mostly with diuretics and RRT. And how much? Again, that's guided by hemodynamics and clinical monitoring. So take-home message is one of the most common interventions is in the ICU we do is assessment of fluid status, prescription of fluid administration or removal. Both interventions have potential harm and benefit. Thus, that is one intervention is resuscitation, and trying to remove is also has its own pros and cons. So they should be IV fluid should be used judicially and according to the principles of fluid stewardship. We must avoid the pendulum swinging back to hypovolemia in patients receiving inappropriately high diuretics. De-resuscitation should be never too fast, too long, or too aggressive. Deciding to start and stop de-resuscitation is a key to improving patient outcomes. Yeah, thank you.
Thank you, Novin. This is a very, very new concept that is coming up, and unlike the previous method of infusing a lot of fluids to maintain the blood pressure, the current status is that we start NORAD and vasopressors also in the early phase itself, so that you don't flush the patient with too much of fluid, and maintain the BP with NORAD or vasopressors, so that you can create a even balance or slightly minimal negative balance to so that you don't congest the organs. Any questions?
Thank you, Philip, and thank you. I'm sorry I came late, Dr. Novin. Thank you. I don't agree with you that this is a new concept. My name is John. I'm a cardiothoracic surgeon, and the cardiothoracic surgeons used to treat chest trauma and lung contusion in the past. Now it goes to the intensivist. Now, in 1972-73, I was an assistant general surgeon in Kottayam District Hospital, and we didn't have any ventilation. And how we managed lung contusion is, I had no ventilator, no ICU in the hospital. So I used to do a tracheostomy to clear their lungs and give them colloids and no crystalloids and a small dose of diuretic. That is how I managed in 72-73. And I was trained in UK after that. And the UK concept was colloids and less crystalloids and dehydrate the patient. The American concept is the crystalloid volume, as Philip said. So whenever I go to the ICU to see a chest trauma, I ask the intensivist, are you giving crystalloid to give volume. I said, yes, we are giving. I said, reduce the crystalloid and give more colloids. And I'm glad you agreed with this concept now. And so it is not a new concept. It's been there for a long time ago. It is forgotten. And then the whole concept changed, yes. Yes.
As Sir rightly said, in the cohort of patients which Sir managed was more of chest contusion. I think this is a new concept. The newness is it's been translated to septic patients. So septic patients, earlier they used to overload with fluids, and now we are moving to a conservative fluids. Thank you, sir.
Thank you, Dr. Novin and Dr. Philip. Coming to the colloids, I mean, what do you mean by colloids? Is it albumin or what is the role of synthetic colloids? Because that is what used to be available earlier and we used to use it.
Yeah, okay.
So do we use synthetic colloids in ICU? Not anymore.
Yeah.
It's only albumin. But what about the cost factor? Is it always affordable? And its role in, is it always feasible?
Now coming to synthetic colloids, we basically have the starches, dextran, So there are a lot of many trials which showed that, especially the 6S, the chest trial, the crystal trial, a lot of huge landmark trials which showed that use of synthetic colloids in the ICU has detrimental to the patient, because most of these colloids, especially the starches, they cause AKI. They cause damage to the endothelial and glycocalyx. So albumin has its role of, it can help in repairing the endothelial glycocalyx. It can used as a fluid expander. Fluid expansion here, 20% is being used, but 5% is what they advocate. Now only in one situation where albumin is not suggested in traumatic brain injury, as per the trials. So Albios trial, all these trials have showed that crystalloids are good enough. And compared to albumin, only in one scenario albumin was better, albumin is not good, was in traumatic brain injury. They still continue to advise giving crystalloids. Colloids, yes, we use in theatre for as a blood sparing agent, but in the ICU we no longer use colloids because of already one, it's there in the guideline. The surviving sepsis guidelines also strictly recommend not to give synthetic colloids, and albumin only has recommendation where you anticipate large volume resuscitation. They suggest albumin, and not the 20% one which we have. And that costs around 8,000 or 9,400 ml, but they suggest 5% albumin. I would request Dr. Philip, maybe he can add on to. So all the trials have shown that avoid colloids. If you're using all the meta-analysis also points out that use only crystalloids. And if you are use colloid, the preferred colloid is 5% albumin, not the 20%. I don't know whether 5% albumin is available. That is the challenge. Once that is made available, the cost factor will come down. And yeah.
Can we make it to 5% with the 20%? Maybe we can make it if it's not available. If 5% is not available, right?
We have not used the 5% here. In the UK, we used to use 5% and 20%. 5% was the commonly used. We can dilute and make it 5% as well, but it's extremely rarely that we use even 20% albumin for resuscitation per se in many of the patients. We should look at having 5% in stock as well. The glycocalyx model has come into existence for the past probably 10 or 15, more than 15 to 20 years. And that is one more reason why we reduce resuscitation, because giving more IV fluids will actually disrupt the endothelial glycocalyx and then worsen the leakage into the interstitium. And the colloid and crystalloid, colloid crystalloid battle. Recently, it was probably in 3 or 4 years back. It was shown that uh, it was a manipulated study for the industry, that it had showed the synthetic colloids had more value than crystalloids, and the papers were withdrawn probably 4 years or 5 years back. It was a German study, I think.
So the bottom line of all the studies which have happened, the papers which I can remember is the 6S, the chest trial, the crystal trial. So all these trials have concluded that crystalloids is sufficient for patients in the ICU. And as Dr. Philip said, if you feel that even after resuscitation, you can start early. The earlier thought I remember was you fill the pipe and then you compress the pipe. You fill the pipes and then you use a vasopressor like noradrenaline. But now there's many other trials which also say that simultaneous starting noradrenaline and IV fluids is much better than going step by step. IV fluids alone, then vasopressor. We can start vasopressor the initial stage and IV fluids along. So the outcomes are also better.
One more question. You had mentioned about the fluid, like how to monitor the fluid status of the patient by clinical features as well as hemodynamics, right? So is there any role of central venous pressure? Because that was the thing available. That's in a normal, when you have a normal LV. Okay, when the LV is failing, you cannot use it. You don't correlate with that. So how often do you use it? CVP monitoring, do you use it now?
No, we don't.
Not
We don't
really.
use the past 8 years here and probably 2 years in the UK. Past 10 years, I have not used central venous pressure for monitoring any of these things. Ultrasound has changed the way we look at venous filling or vascular filling. In addition, airline pulse pressure variation, so many other things have come up. Again, for ventilated patients, the CVP will change a lot. In critical care, definitely 80% of the patients would be in hemodynamic, would be on NIV or ventilator or some of those things. So that doesn't form a reliable part of measuring.
Generally, the role of CVP has come down. I mean, this was there long back. Just wanted to confirm it in ICU. That's all.
CVP is still used in, I think, in cardiac ICUs. But in sepsis patient and the sepsis guidelines, they suggest more of a dynamic parameters are more important than static. So CVP is like a static parameter of hemodynamic assessment, but we are moving into more of a dynamic assessment where the beat to beat variability of hemodynamic status is now available. Yeah.
Just want to thank Dr. Novin for bringing this to our attention again, readdressing this problem, which has always disturbed me, the fluid management in the ICU. And thank you for bringing it and readdressing it. Thank you.
Thank you all. Thank you, Dr. Novin. Thank you for all you have joined in today's quest. Have a blessed day.